I'm Miss Delima. I know talking about pathogens is not the best way to initiate a conversation, but aren't you curious about what the virus is? If you are, then I guess we can be soulmates. You see, whenever I heard about viruses in the news, I always thought it sounded cool. Of course, except at one time when we had to study about it. Hey, it's not like the topic was not interesting, it's just that all the terms, so they sure did made my head spin. But going back, let me tell you some of the important things I learned about that virology lesson. Let's begin by talking about what viruses are. Viruses are submicroscopic pathogens whose size is measured in nanometers. In fact, they are so small they turned out to be the smallest infectious agent with nucleic acid. Their basic structure consists of a core of DNA or RNA packaged into a protein coat or capsid. In some viruses, the capsid is surrounded by an outer envelope of glycolipids and proteins derived from the host cell membrane. Viruses might be tiny, but I kid you not, they are still capable of causing severe and sometimes lethal disease in humans, ranging from childhood infections to inflammatory diseases with a predilection for a specific organ, disseminated disease in immunocompromised patients, cancer, and congenital abnormalities. If that did not catch your interest, then I suppose your lack of empathy is no longer my problem. Or is it? Anyways, if that did not catch your interest, then I suppose this will. Viruses are obligate intracellular pathogens that rely on the host cell for their replication and survival. As a summary, they infect their host cells by attaching to specific receptors on the cell surface, penetrating the host cell membrane, and releasing their nucleic acid, which then directs the host cell's machinery to produce more viral nucleic acid and proteins. These components assemble to form intact viruses that are released by lysis of the cell or by budding off the cell surface. Replication can occur quickly in cytolytic viruses that produce acute infections or slowly in viruses that result in chronic infections. The free variants that are generated can then infect neighboring host cells and begin new replication cycles that promote dissemination of the infection. Thus, viruses can be present in the host as both freely circulating particles and intracellular particles. So, enough of the general information. Hopefully, we're able to absorb all that because in this report, some of the most important viral infections detected by serology and molecular methods will be tackled. These include the hepatitis viruses, herpes viruses, measles, mumps, rubella, and human T-cell lymphotropic viruses. They sound like a lot, right? But hey, don't you worry. I bet it would not be as difficult as you think. Besides, I would not be the only one who would help you understand our topic. Here, meet Miss Candelario, Mr. Desacada, Miss Garde, Miss Sandoval, Miss Miguel, and Miss Mendoza. Together, the seven of us will teach you everything you should know about our assigned topic entitled Serology and Molecular Detection of Viral Infections. To continue, Miss Candelario and Miss Miguel will be taking my place. They will be mentioning a lot about immune defense against viral infections, so be sure to listen, okay? Okay.
Okay, so hi, I'm Allen and I'll be now discussing the immune defenses against viral infection. So as we all know, most viruses that infects humans or the most clinically important viruses only causes little to mild symptoms in an immunocompetent individual. So this is because us humans have defenses against these types of pathogens, meaning we are not defenseless in this type of infections mainly because of our immune system. Okay, so immune defenses against viral infections includes your innate defenses, your humoral antibody responses, and of course your cell-mediated immunity. So when we say innate defenses, as discussed by mom, this is our natural and inborn defenses. So we all know that this includes our skin and mucous membrane barriers, and others included with this is your secretions and yung mga physiologic like coughing, sneezing, and the like. Okay, so recognition of pumps on virus infected host cell. Again, when we say pumps, this is the pathogen associated molecular pattern, and then of course the interferons alpha and beta. So emphasizing on interferon, this is a natural defense on our system that specifically is antiviral in nature. That is the reason why it is prominent specifically or especially during viral infections. Okay, so when it comes to humoral antibody responses, this includes na your antibodies that are produced by your plasma cells and that attacks free virus particles. When we say free, meaning it still doesn't invade the cells or they are still in the circulation. So they are not attacking pa within the cell. So these responses are actually manifested through your viral neutralization, opsonization, complement fixation, and the ADCC. Pag sinabi natin ADCC, this is the antibody-dependent cell cytolysis. Okay? So as per the cell-mediated immunity, this includes your interferon gamma and interleukins 2 produced by your T helper cells type 1. Okay? Also, the host cells containing intracellular viruses destroyed barrier CTL or the cytotoxic T lymphocytes. So, true for example, itong cell-mediated immunity is yung perforin granzyme that we have discussed in our adaptive immunity. So, ang difference naman ito when it comes sa humoral antibody responses is kapag cell-mediated immunity na yung nagre-respond, meaning the virus or the infection is within the cell na. Okay? So, next is let's give it to Mary Grace to give us some overview regarding the immune defenses against viral infection.
Thank you, Alan. Good morning, everyone. I am Mary Grace A. Candelario, and now let's see how does immune defenses against viral infections work. Okay? Focus po tayo dito sa picture na nasa presentation. So makikita natin dito yung epithelium natin ay nagkaroon ng space at dahil doon nakapasok ang ating virus. Ito po yung virus natin, yung may arrow dyan. Yan, makikita po natin yung icosahedral nating virus. So ano nga bang mangyayari once na mapasukan yung body natin ng virus? So ang mangyayari po dyan, magre-release po yung katawan natin ng interferons. Interferons A and interferons B. Dun po sa interferons A, magbabind po yan sa ating host cells. Yan po yung mga cells natin. Tapos ang mangyayari po dyan, di ba po yung virus, pupunta po siya sa mga cells natin. Ang gagawin nitong interferons alpha, pupunta rin siya dun sa ating cells para yung mga virus na dumidikit dun sa ating host cells, ang gagawin po ng interferons ay magsisikret din sila ng mga product or ng mga proteins na makakapag-degrade doon sa nucleic acid at proteins na meron yung virus na pumasok dito sa ating body. Then, aside from that, yung interferon beta naman na marerelease ng katawan natin, isi-stimulate niya yung pagka-release na ating NK cells, itong natural killer cells, or yung label po dyan ay letter C. Then, bukod doon, makakapag-secrete din yung body ng toxic cells or cytotoxic T cells para doon naman sa ating mga virus din. Para ang mangyayari dyan, di ba yung yung virus natin, didikit siya sa ating host cells. Ang mangyayari, yung interferon alpha, siya yung pupunta doon sa ating host cells para labanan itong mga virus. Then ito namang interferon beta is stimulate niya yung pagka-create ng natural killer cells tsaka ng cytotoxic T cells para labanan din itong virus na meron nga doon sa ating host cells. Tapos, ang mangyayari dyan, yung joint force ng alpha and beta cells natin, ang mangyayari, masisikret yung virions na meron doon sa ating virus. Yung virions na yun, kapag nagkaroon ng secretion ng virions, ang mangyayari, makakapag-stimulate yung body ng B cells na
kung saan virion specific itong B cells na 'to. Yung virions na mula doon sa pagka-degrade or pagka-release doon sa mga, nangyari dun sa T cells 'yan, pati dito sa NK cells. Yung virions na mula dun sa virus na yun, tsaka yung virions na nag-penetrate doon sa epithelium natin, parehas iyan na ma-recognize ng ating antibody-specific na B cells. Once ma-recognize ng B cells yung ating virions at magkaroon ng binding, ang mangyayari mag-stimulate na yung ating antibody. At once ma-stimulate na yung production ng antibody natin, dun na mag-i-start yung neutralization, opsonization, complement activation, or ito nga yung process na to, ang tinatawag dito ay antibody-dependent cell-mediated cytotoxicity. And with that, yun na, mapapatay na yung virus na pumasok sa ating body.
Next we have is the viral escape mechanism, or simply how the virus escape. So the term viral escape mechanism refers to the strategies employed by the viruses to evade the host's immune system. There's antiviral drugs or other therapeutic interventions. So viruses have evolved various mechanisms to survive and replicate within the host organism, and it often adapts to counteract the host defenses mechanism. And here are the some of the common viral escape mechanisms. So we have the mutation, innate immune system modulation, adaptive immune system suppression, and latency and persistence. So for the mutation, so we all know that viruses are rapidly dividing agents that undergo frequent genetic mutation. And this rapid mutation allows the viruses to generate diverse variants, and some of which may be less susceptible to the immune recognition or antiviral drugs. So, for example, we have the continual antigenic variation in the influenza virus, which results in the emergence of novel infectious strains that require development of new vaccines every year to protect the population. This is also seen in the rhinoviruses, which causes common colds, as well as the HIV or human immunodeficiency virus, which causes AIDS. Next, we have for the viral escape mechanism, we have the innate immune system modulation. So, for the innate immune system modulation, some viruses can escape the action of components of the immune system, such as the interferons, complement proteins, or the lysosomal enzymes in the phagocytic cell. So, for example, the hepatitis C virus can block the interferon mediated degradation of the viral and RNA, and herpes simplex virus or HSV produces a protein that binds to the CB, complement component CB3, resulting in the inhibition of complement pathways. So this mechanism helps the virus to evade detection and clearance. So to further infect the host.
Another way in which viruses can escape the host defense mechanism is by suppressing the adaptive immune system of the host. For example, Epstein-Barr virus produces a protein that can suppress Th1 cells because of its similarity to interleukin 10, resulting in inhibition of immune responses. Finally, certain viruses establish latent infections where they remain dormant within host cells. Herpes virus such as herpes simplex virus and varicella zoster virus can enter a latent phase, making it difficult for the immune system or antiviral drugs to target them. Understanding this viral escape mechanism is crucial for developing effective strategies to combat viral infections. Researchers continually study these mechanisms to design vaccines, antiviral drugs, and therapeutic interventions that can target and counteract viral evasion strategies. The ongoing evolution of viruses poses a significant challenge, emphasizing the importance of ongoing research and surveillance in the field of virology.
Good day. I'm Rin Angelo de Sacada and I will be discussing the laboratory testing for viral infections to be followed by Ms. Lois Sandoval. In the realm of diagnosing viral infections, two pivotal laboratory tests, namely serological and molecular tests, play a crucial role in establishing presumptive diagnosis, facilitating prompt initiation of treatment. Serological tests serve multiple purposes, ranging from monitoring the course of infection to detecting past infections and assessing immune status. They provide valuable insights into the patient's overall condition, allowing healthcare professionals to tailor treatment plans accordingly. On the other hand, molecular tests are instrumental in detecting active viral infections, offering a real time snapshot of the ongoing viral activity. This is not only aids in confirming the presence of the virus, but also guides in the initiation of specific antiviral therapies. Together, these two types of tests form a comprehensive diagnostic approach, enabling timely and effective interventions in the management of the viral diseases.
Okay, so to continue with the laboratory testing for viral infections, Rin already mentioned that we often use serological tests and molecular tests. And in general, the presence of virus specific IgM antibodies in patient's serum signifies current or recent infections. IgG antibodies to a virus means that there is current or past infections as well as immunity. Congenital infection naman is indicated by the presence of IgM antibodies in newborn serum, while IgG antibodies signifies maternal antibodies.
In continuation, we will discuss about the hepatitis, and I will be specifically tackle the Hepa A and Hepa B, and the rest will be discussed by Miss Mendoza and Miss Garde. Hepatitis A virus or HAV is a non-enveloped single-stranded RNA virus belonging to the hepatovirus genus. It is transmitted through the fecal-oral route, person-to-person contact, or contaminated food or water ingestion. Incubation is around 28 days with symptoms of acute hepatitis in adults and often asymptomatic infections in children. As I said earlier, the incubation is around 28 days. So, the virus rarely progresses to a chronic state and is typically self limiting. Diagnosis relies on serological tests for antibodies, particularly IgM and IgM anti HAV, detected by automated immunoassays. False negatives may occur early in infection, where molecular methods like RT-PCR are more sensitive. A vaccine has significantly reduced global HIV infections, and prophylactic measures are recommended for exposed individuals, including vaccination and immune globulin administration within 2 weeks of exposure. Next is hepatitis B. Hepatitis B is a global health concern, affecting 2 billion people and causing 780,000 deaths annually. While more prevalent in certain regions, even low prevalence areas like the United States report 1.2 million chronic infections and 1,800 deaths yearly. Transmission occurs through contact with infected bodily fluids or blood, and preventive measures include screening, treatment of blood products, infection control, and vaccination. Vaccines produced from genetically engineered yeast or mammalian cells have significantly reduced acute hepatitis B cases since 1991. Despite these efforts, a considerable number of infections persist, leading to acute and chronic conditions. Chronic infections, affecting 90% of infants, 30% of young children, and 10% of adults, pose a risk of cirrhosis or hepatocellular carcinoma. Antiviral drugs can manage chronic infections, but 1% may progress to fulminant liver disease. The hepatitis B virus is a DNA virus with 8 genotypes, and serological markers aid in diagnosis, monitoring, and screening. The ABSAG is the initial marker, followed by HBEAG. When HBsAg is detectable 2 to 10 weeks after exposure, and HBsAg appears shortly after the HBsAg, or the HBeAg rather. The HBsAg is the initial marker, followed by the HBeAg, and the appearance of antibodies indicates recovery. Molecular methods like PCR play a role in early detection and assessing antiviral therapy effectiveness. These strategies contribute to global efforts to combat the impact of hepatitis B.
Good day, I'm Abigail Mendoza and I'll be discussing hepatitis types C and D. So, starting with hepatitis C, in the past, hepatitis C was considered a disease limited to transfusion recipients. Now, HCV is recognized in many other epidemiologic settings and as major cause of chronic hepatitis worldwide. So hepatitis C is a small, enveloped, single-stranded RNA virus caused by the hepatitis C virus or HCV in short. It is previously called non-A, non-B hepatitis. Around the world, hepatitis C infection exists in several forms, called genotypes. There are 7 genotypes and 67 subtypes. So, hepatitis C is a liver infection caused by the hepatitis C virus. Hepatitis C can range from a mild illness lasting a few weeks to a serious long-term illness. Hepatitis C can be acute or chronic. Acute hepatitis C occurs within the first 6 months after someone is exposed to the hepatitis C virus. Hepatitis C can be a short-term illness, but for most people, acute infection leads to chronic infection. For chronic hepatitis C, this can be a lifelong infection if left untreated and can cause serious health problems including liver damage, cirrhosis or scarring of the liver, liver cancer, and even death. The hepatitis C virus is usually spread when someone comes in contact with blood from an infected person. This can happen through sharing drug injection equipment. Today, most people become infected with hepatitis C by sharing needles, syringes, or any other equipments used to prepare and inject drugs. Birth. Approximately 6% of infants born to infected mothers will get hepatitis C. Healthcare exposures. Although uncommon, people can become infected when healthcare professionals do not follow the proper steps needed to prevent the spread of blood-borne infections. Sex with an infected person. While uncommon, hepatitis C can spread during sex, though it has been reported more often among men who have sex with men. Unregulated tattoos or body piercings. Hepatitis C can spread when getting tattoos or body piercings in unlicensed facilities, in formal settings, or with non-sterile instruments. People can get infected from sharing personal items, including razors, nail clippers, toothbrushes, and other items that may have come in contact with infected blood, even in amounts that are too small to see. Blood transfusions and organ transplants. Before widespread screening of blood supply in 1992, hepatitis C was also spread through blood transfusions and organ transplants. Now, the risk of transmission to recipients of blood or blood products is extremely low. It is important to note that hepatitis C is not spread by sharing eating utensils, breastfeeding, hugging, kissing, holding hands, coughing, or sneezing. It is also not spread through food and water. For treating hepatitis C, current treatments usually involve just 8 to 12 weeks of oral therapy and cure over 90% with few side effects. It is recommended for all people including non-pregnant women with acute or chronic hepatitis C. Prevention. Unlike hepatitis A and hepatitis B, there is no available vaccine to prevent hepatitis C. Over the years, the treatments for hepatitis C have become more effective. However, treatment is not for everyone and a specialist should be consulted when determining if someone should get treated. We will now proceed with the discussion of hepatitis D. HDV or hepatitis D is known as satellite virus because it can only infect people who are also infected by the hepatitis B virus or HBV. Hepatitis D can be acute or can lead to chronic long-term illnesses. This can also be acquired either simultaneously with hepatitis B virus as a co-infection or as a superinfection in people who are already chronically infected with hepatitis B virus. So HDV is mainly transmitted through activities that involve percutaneous, that is, puncture through the skin, and the lesser extent through mucosal contact with infectious blood or body fluids such as semen and saliva. So this can be acquired through sex with an infected partner, injection drug use that involves sharing needles, syringes, or drug preparation equipment, birth to an infected mother, which is rare, contact with blood from or the open source of an infected person, needle sticks or exposure to sharp instruments, and sharing items such as razors and toothbrushes with an infected person. It is also important to note that hepatitis D virus is not spread through food or water, sharing eating utensils, breastfeeding, hugging, kissing, hand-holding, coughing, or sneezing. For the diagnosis and treatment of hepatitis D virus, hepatitis D virus are not clinically distinguishable from other types of acute viral hepatitis. Diagnosis can be confirmed only by testing for the presence of antibodies against HDV or HDV RNA. HDV infection should be considered in any person with a positive hepatitis B surface antigen who has severe symptoms of hepatitis or acute exacerbations. For the treatment of hepatitis D is a severe and rapidly progressive liver disease for which no therapy has proven effective. Although no vaccine is available for hepatitis D, vaccination with hepatitis B vaccine can protect people from hepatitis D infection.
Next, we have the hepatitis E virus. And hepatitis E virus is a positive sense, non-enveloped, single-stranded RNA that belongs to the genus of Hepavirus in the family of Hepaviridae. And hepatitis E is a global health concern as it is a major cause of hepatitis worldwide. And according to the World Health Organization, it is estimated that annually the virus causes 20 million infections and over 3 million cases of acute hepatitis, with 56,000 deaths. And similar to the hepatitis A virus, hepatitis E is transmitted primarily by the fecal occult route, while person to person transmission is rare. And as I mentioned, drinking contaminated water and eating contaminated food is also a how you get a hepatitis E virus. Next, hepatitis E and its genotypes. So, hepatitis E has multiple genotypes with variations in geographic distribution. The four genotypes of the virus differ in terms of their epidemiology and source of infection. So, hepatitis E with genotypes 1 and 2 are associated with human infections, primarily with consumption of fecally contaminated drinking water in developing regions of the world with poor sanitation, including parts of Africa, Asia, Middle East, and Mexico. And outbreaks are which commonly occur in times of natural disasters such as flooding and earthquakes can affect thousands of individuals. Next, we have the genotypes 3 and 4, which can infect humans and animals. So genotypes 3 and 4 are zoonotic infections in which pigs are primarily the hosts. And genotypes 3 and 4 have been increasingly recognized in developed parts of the world, including Europe, North America, and Japan. And these infections are thought to be transmitted mainly by consumption of infected pork and possibly by direct contact of infected animals or fecally contaminated water. And back to this slide, under the transmission, um, it is said that hepatitis E virus can also be transmitted through blood transfusions. And I know. We go back and although hepatitis E virus infections are often silent, all genotypes, which are genotypes 1, 2, 3, and 4, are capable of causing acute hepatitis, with symptoms that are indistinguishable from other types of hepatitis, which are hepatitis A, B, C, and D. And following an incubation period of 2 to 6 weeks, hepatitis E infection in most people causes a self-limiting illness, with recovery occurring by 4 to 6 weeks. And symptoms include jaundice, fatigue, abdominal pain, and nausea. But severe cases can lead to acute liver failure. Ayan. The infection can have severe consequences, and some patients may experience extrahepatic symptoms, including neurological syndromes, renal injury, pancreatitis, and hematologic abnormalities. And pregnant women infected with hepatitis E virus 1 or hepatitis E virus 2 have a mortality rate of 20% to 25% because of obstetric complications or development of fulminant hepatitis, which is associated with rapidly progressing liver disease and liver failure. Liver failure. And the reason for this is unclear, but it may be caused by the hormonal and immunologic changes associated with pregnancy. And we have hepatitis E virus 3 can result in chronic infections, especially in immunocompromised individuals. And this chronic infection can progress to liver fibrosis, liver cirrhosis, and liver failure, which may require liver transplantation. Next, hepatitis E virus prevention. And the measures to prevent the infection include provision of clean drinking water as well as improvement of sanitations in developing countries. And in the case of hepatitis E virus 3, avoidance of eating of undercooked meat, especially pork, is advised. And there is a vaccine to prevent hepatitis E virus 1 infection, and it has been licensed for use in the People's Republic of China. And this vaccine consists of virus like particles that have been genetically modified to express a gene that codes for a key HEV protein. So, again, we have to ensure the access to clean and safe drinking water as well as to promote good sanitation and hygiene practices. And vaccination is available in some regions and can be an effective preventive measure. So there is no specific antiviral treatment for hepatitis E, but we can diagnose hepatitis E virus. So since hepatitis E virus is not easily cultured, diagnosis relies in serology to detect the antibodies to the virus and molecular methods. So to detect the hepatitis E virus nucleic acids, we have the diagnosis antibodies to hepatitis E virus are identified by enzyme immunoassays that use recombinant and synthetic HEV antigens. And rapid immunochromatographic assays have also been developed, as well as antibody tests for HEV, which can detect all four genotypes of the virus, as we mentioned before. And since there is only one viral serotype, so this antibody test can detect all four genotypes of the virus since there's only one viral serotype. And next we have the acute infection is indicated by the presence of IgM, anti-HEV, and HEV specific IgG antibodies, which is detectable at clinical onset and remains elevated for about 8 weeks and becomes undetectable in most patients by 32 weeks. And these HEV specific IgG antibodies appear soon after IgM and reach peak levels about 4 weeks after symptoms develop and persist for several years. So, immunoassays for IgG and anti-HEV may be performed to detect patients in the later stage of infection. We have to determine the past exposure and identify the seroprevalence of the infection in a population. And immunocompromised person often yield negative antibody test results. So, molecular testing for hepatitis E virus RNA is recommended for these patients to those who develop negative antibody test results. So, we have nu- this HEV nucleic acid can be performed by real-time PCR or a loop-mediated isothermal amplification assay or LAMP, which is suitable for resource-limited settings because it is faster and it does not require expensive equipment. And these assays can be performed on blood samples or stool samples. And also, hepatitis E virus RNA can be detected before clinical symptoms appear, and it becomes undetectable in the blood about 3 weeks after symptom onset in the stool. And in the stool, it becomes undetectable about 5 weeks. So therefore, a negative result for HIV RNA does not include the possibility of recent infection. Next, we have the hepatitis viruses summary. Here we included the hepatitis virus, type and family, how it is transmitted, if it does progress to the chronic state, the complications, and serological and molecular markers, as well as the clinical significance. We have the hepatitis A and the hepatitis B. So, whoever's watching this can just pause and review if you want to review the past discussions from our members. So we have hepatitis A, hepatitis B, and then next slide, we have the hepatitis C, hepatitis D, and hepatitis E. And you can just pause it and read it so that you can understand it the better more. And that's all for the hepatitis virus in serology and molecular detection. Next.
Okay, so hi again, this is Alan, and we will gonna be moving on into herpes virus infection. So, as we have recently studied on mycovirology or mycology and virology, herpes viruses are included in the family of Herpesviridae, which is a group of DNA viruses. Actually, there are a lot of members of the Herpesviridae, but we are gonna be focusing on three, which is the Epstein-Barr virus, the cytomegalovirus, and of course varicella zoster virus. Okay. So Epstein-Barr virus. So we have, or as I mentioned again, we have already learned about this on our virology. So let's discuss this briefly. So this DNA herpes virus can cause spectrum of diseases. Okay, though this primarily involves your infectious mononucleosis. So infectious mononucleosis is more commonly known as the kissing disease, as this is primarily transmitted through saliva. Okay. So cases of this is very common on teenagers and young adults, specifically those that has multiple kissing partners. Okay, so lymphoproliferative disorders and certain malignancies such as Burkitt, Burkitt lymphoma. So this Burkitt lymphoma is very particular in Epstein-Barr virus, and this is actually associated with your ALL, so yung ating acute lymphocytic leukemia, and specifically the L3 since there are three types of ALL, di ba? So most commonly transmitted ito by intimate contact and salivary secretions as I mentioned, and this begins in your oropharynx in the B cells and epithelial cells and spread through the lymphoreticular system. So in B cells, this is actually their site of latency. So ibig sabihin ito yung stage from which the virus is undetectable or hiding pa. So, yun yung ibig sabihin kapag sinabi nating latency. And as per Epstein-Barr viruses, yun daw ay nangyayari sa kanilang B cells, okay? Or sa ating B cells. Okay, so Epstein-Barr virus antigen. So, by here, the table we will discuss ano-ano ba yung particular antigen of Epstein-Barr virus that we detect on different phases of the infection. So, this is primarily on early acute phase, late phase, and the latent phase. So, as early acute phase, we can detect EAR or the early antigen restricted and the EAD or the early antigen diffuse. And as per late phase naman, we can detect the BCA or the viral capsid antigen and the MA or the membrane antigen. And on the latent phase, dito na yung marami siyang pwedeng ma-detect since matagal na yung infection. So this includes your EBNA or the Epstein-Barr virus nuclear antigen. The EBNA 1, 2, and 3 is the types of the EBNA. This also includes your 3A or the EBNA4, the 3B, the EBNA5, the LP, and the EBNA6, the 3C. So other latent membrane proteins also the LMP1, the LMP2A, and your LMP2B. Okay. Okay, so let's us discuss ano ba yung infectious mononucleosis. Is ito talaga yung pinakang particular na infection when we talk about Epstein-Barr viruses. Okay, so infectious mononucleosis, ang causative agent na, as I said, is Epstein-Barr virus. And classic symptoms may include fever, lymphadenopathy, sore throat, and fatigue. So as per laboratory findings, makakita tayo dito ng absolute lymphocytosis, 20% or more atypical lymphocytes. So if we can remember in our hematology, the WBC anomaly na part, this is what we can see in the picture. Ayan, naka-present dyan. This portrays the Downy cell. So, as you can remember, which is one of the hematologic findings in an infectious mononucleosis. Okay? So, this also present, or we also detect here the presence of heterophil antibody, primarily detected on monospot, Paul Bonnell test, and rapid agglutination test or immunochromatographic assays. Okay, so let's focus on the monospot test as this is the test that is primarily indicated in Epstein-Barr viruses infection, specifically the infectious mononucleosis. Okay, so monospot test is a form of heterophil antibody test. So this is a rapid test for infectious mononucleosis due to Epstein-Barr virus. So here in the demonstration, we detect the IgM antibody that is present in the patient cell. So, after cross-reactivity, we will know that it is positive kapag nag-form siya ng agglutination. Okay? So, sabi dito, sensitivity is 90 to 95% after the first week, but only 75% in the first week. So, meaning, in conducting the monospot test, we have to wait for at least 1 week for us to prevent false negative results since mas detectable or mas sensitive yung test na to after 1 week ng infection. So second, yung specificity niya is 94% and nagkakaroon lang daw siya ng false positive results sa infections like CMV, toxoplasma infections, acute HIV, malignancies, and autoimmune diseases such as your systemic lupus erythematosus. So being the reason, yung pagkakaroon ng mga false positive results, kaya hindi na siya recommended by the CDC, okay? It is no longer recommended by the CDT due to confusing false positive and false negative results. Okay, so to minimize the confusion, here are the serological responses of patients with Epstein-Barr virus-associated diseases. Okay, so for the legend, these tables in the lower part naman, where EAD means early antigen diffuse, the EA again is the early antigen restricted, and the EBNA, the Epstein-Barr virus nuclear antigen. So as you can see, an uninfected individual, of course, will be negative in every marker. So as you can see, ayan, negative siya lahat. So, in an acute infectious mononucleosis naman, they are positive in IgM and IgD. As per the convalescent IM, they are positive in IgE and anti-EBNA. So, ang difference niya with past infection is with their heterophil antibody from which the heterophil antibody is negative in the past infections. Okay? So, in chronic active infection of mononucleosis or infectious mononucleosis, very positive siya or strongly positive siya in IgG. Same with post-transplant lymphoproliferative disease and the Burkitt lymphoma, as well as the nasopharyngeal carcinoma. So as you can see, they are highly positive sa IgG. Ayan, almost similar silang. Okay, so let's proceed with the varicella zoster virus. So this is also a DNA herpes virus transmitted primarily by inhalation, respiratory secretion, or aerosols from skin lesions. So this causes your varicella or your chickenpox and your herpes zoster or your shingles. So remember that shingles is a latent infection of chickenpox, which we can remember as the more painful version of chickenpox because the infection here is on the sensory neurons na or the peripheral nerve endings na which is where our pain receptor is, diba? So primary infection, the varicella zoster virus travels from the skin lesions and the blood to sensory neurons as I mentioned dun sa nangyari nga sa herpes zoster virus. So there is reactivation of BCB. So pag sinabi natin na reactivation of BCB meaning even if you had chickenpox na in the past, it can still be reactivated, especially if you are an immunocompromised individual. So, we cannot make sure na yung sinasabi natin na we already had chickenpox, eh hindi na siya mauulit kasi there are cases nga that there have been reactivations of your BCB. But luckily, your varicella zoster virus naman is preventable by vaccinations.
Okay, so for the laboratory diagnosis of BCV, it is usually based on the characteristic of the clinical finding. So first, we can perform viral culture, however, hindi siya recommended due to it being time-consuming and it may not yield productive result if the specimen contains insufficient amount of the virus. We can also perform stain smear from the vesicle to detect the presence of sunk cells, but the problem here is that we cannot distinguish varicella zoster with herpes simplex virus. In terms of molecular testing naman, we can perform direct immunofluorescent staining of scraping which is rapid, sensitive, and specific. Pero ang method of choice pa rin natin to diagnose varicella zoster infection is real-time PCR. And serological testing, of course, it is useful in determining the immunity. However, its use is limited due to its long observation period. Okay, lastly, for herpes virus infection, we have cytomegalovirus or CMV. So this virus primarily infects the WBCs in vivo, and it is transmitted via close contact with infectious body secretions, sexual contact, blood transfusions, solid organ transplant, and perinatal exposure from infected mother to infant, although less likely na mangyari if seropositive si mother. And primary infections of healthy individuals are usually asymptomatic, but some manifest as self-limiting infectious mononucleosis-like illness, especially sa mga immunocompromised individuals like mga organ transplant recipients and patients with HIV or AIDS, or pwedeng mas worse pa dyan like hematologic abnormalities, CNS, and gastrointestinal involvement. So, CMV is the most important infectious agent kapag sinabing organ transplantation because it poses high risk of allograft failure or graft versus host disease. Sa case naman ng mga HIV or AIDS patient, CMV is considered as the major opportunistic pathogen in patients with low CD4 or T cell counts. And also, CMV is considered as the most common cause of congenital infection through the placenta and contact with maternal secretions. Okay, let us now proceed sa laboratory diagnosis ng CMV. So currently, there are several laboratory methods that we can use to detect and diagnose CMV infection, primarily through direct detection and serological and molecular tests. So first thing that we can perform is culture. So this is a traditional method of direct viral detection using human fibroblast cell lines inoculated with CMV-infected specimen. So positive result is cytopathic effects appearing as enlarged, rounded, refractile cells. So although culture provides definitive results, limited lang yung gamit niya kasi mahaba yung incubation period niya, which is mga 3 weeks. That's why mas prefer natin ang paggamit ng shell vial. So we can detect the virus within 24 hours. Ang positive result dito is fluorescent stain in the nuclei. Another common direct detection method is CMV antigenemia assay. So this detects the CMV lower matrix protein PP65 in infected leukocytes through immunocytochemical and immunofluorescent staining. So this assay is gaining wider use kasi we can detect the virus within 2 to 4 hours, and it also can give quantitative result. And ang positive result sa kanya is fluorescent stain in the nuclei. We can also use real-time polymerase chain reaction, which is the preferred method in determining the viral loads. So this method detects the presence of CMV DNA or mRNA, which is the gold standard in confirming fetal infections using amniotic fluid. So lastly, we have semi or fully automated enzyme immunoassay, which is a serological method. However, isa pa to sa mga limited lang yung gamit niya. So nevertheless, this method is helpful in distinguishing past exposure and current primary infection. So low avidity to IgG antibodies signifies recent infections, while high avidity to IgG antibodies signifies past exposure.
And to continue this presentation, I will be discussing the other viral infections, particularly the rubella virus and rubiola virus. Let's start. First we have here is the rubella virus. What is rubella virus? Rubella virus or rubivirus is a single-stranded envelope RNA virus of the genus Rubivirus that belongs to the family Tagaviridae. So here po sa picture, pinapakita lang po yung structure ng ating rubella virus, which is pinapakita po dyan na isa po siyang icosahedral nucleocapsid at meron po siyang glycoprotein and lipid bilayer. Makikita rin po dyan yung positive single-sense stranded natin na RNA. Kaya po siya kabilang dun sa RNA viruses natin. And for the transmission naman po, it is transmitted via aerosol droplets or transplacental. So, before po ng widespread ng ating vaccine para dito sa rubella virus, this rubella virus is considered as child disease ibig sabihin po nun mas particular siya or mas nai-infect niya yung mga children compared sa adults. Pero today po, as of today, um, makikita po sa ating census na mas infected na po yung mga adults natin. So, paano nga ba 'to nata-transmit? Mag-i-start po yung virus mag-replicate sa ating upper respiratory tract, then kakalat po siya sa ating cervical lymph nodes and hanggang sa kumalat na po siya sa ating bloodstream. Next. So, rubella virus is also known as German measles or third disease. And then, usually, Usually, this virus po, when you are infected by this, asymptomatic lang yung mangyayari sa'yo or no signs and symptoms at all. Ibig sabihin, hindi siya malala except na lang doon sa mga immunocompromised persons. And with that, 50% ng nai-infect ng virus na to are asymptomatic and meron din po siyang 12 to 23 days na incubation period. Yung signs and symptoms when you are infected with this virus is very similar to rubella or measles, kung saan magkakaroon po tayo ng mild fever, plus erythematosus maculopapular, discrete rash, yun po yung makikita nyo sa picture which is nagsisimula yung rash na iyan sa face ng infected person hanggang sa kumalat na po sa trunk and extremities. Bukod doon, nagkakaroon din po tayo ng post-auricular and sub-occipital lymphadenopathy. Tapos, yung isa naman sa signs and symptoms na makikita sa mga adults na unvaccinated or hindi pa nagkakaroon na unvaccinated nga ay nagkakaroon po sila ng transient polyarthritis. Dito po sumasakit yung kasukasuhan. Itong transient polyarthritis na to, it is much common in adults pero yung mga bata or children ay pwede rin po magkaroon nito. So, to continue po, yung pinakamalalang epekto ng ating rubella virus ay yung congenital rubella syndrome. Ano nga ba yung nangyayari dito? So, yung rubella virus ay nagkakapag-cross dun sa placenta ni mother at dahil nga doon na ikakalat yung virus sa ating fetal tissue. With that, it will lead to severely impaired infant na kung tinatawag nga ay blueberry muffin baby kasi nagiging cyanostic po yung infant dito at it will lead to fetal death o kaya naman spontaneous abortion. Yung congenital rubella syndrome or CRS ay may two forms. Yung isa ay mild and then yung the other one naman is yung severe. Kapag mild, later or months to years pa after makakita yung simptomas ng CRS. Pero kapag severe naman yung naging infection kay baby ay magkakaroon agad ng mga signs and symptoms kung saan makikita dito yung pagkabingi or kaya naman nagkakaroon ng glaucoma yung baby at bukod pa doon nagkakaroon din ng katarata, then nagkakaroon din ng cardiac abnormalities, mental retardation at saka motor disabilities. So next is for the diagnosis. Paano nga ba dinadiagnose ang rubella virus? So dito sa rubella virus, just like doon sa iba pa nating child disease, mas ginagamit ng mga physician yung signs and symptoms. Pero if you want to choose pa rin yung mga ating ibang pang-isolate, yung viral isolation dito ay hindi masyadong ginagamit kasi mahirap or laborious itong gawin. Pero kung yun nga, want nating mag-viral isolate, pwede rin yung nasopharyngeal secretion or kaya naman mag-urine culture tayo under 33 degrees Celsius gamit yung primary monkey cells. Aside from that, ginagamit din yung enzyme immunoassay kung saan ito ay yung direct detection natin ng virus. At bukod doon, gumagamit din tayo ng mga serological testing which is used sa mga mother para makita nga kung kung makita nga kung may infect ba sila nitong rubella virus kasi baka nga magkaroon ng CRS yung baby. Bukod doon, meron din tayong MMR vaccine kung saan available ito. Kasama ng MMR yung mumps, measles, and rubella. So next virus we have here is rubella virus. So rubella virus is under the child's disease, which is also known as the first disease or red measles. Rubella virus is a single-stranded RNA virus that belongs to the genus Morbillivirus in the family of Paramoxyvillidae. So, paano nga ba to natatransmit? So, first we have here is through aerosol droplets. Then, it will disseminate through the blood to multiple sites in the body, such as the skin, lymph nodes, and liver. So what are the clinical manifestations when you are infected with this virus? So we have here the sneezing, runny nose, cough, red eyes, and rapidly rising fever. At yung pathognomonic sign nito ay yung Koplik spots. So dito po sa picture makikita natin yung Koplik spots, which is bright red spot na merong white or bluish white na center na nag-a-appear po as sandy appearance. Yun. After po niyan magkakaroon followed by 2 to 3 days na maculopapular rashes na meron po sa head and trunk. Ano pa ba yung other complications under this virus? We have here the diarrhea, otitis media, croup, bronchitis, pneumonia, and encephalitis. So, yung isa naman po sa fatal complication na pwedeng mangyari, pero rare lang naman siya na nangyayari, is yung subacute sclerosing panencephalitis. Next, how to diagnose this virus. Katulad din kanina ng rubella virus kung saan yung clinical presentation na yung pinagbabasihan ng mga physician. Bukod doon, yung cell culture, hindi rin siya masyadong ginagawa. Then, kung magma-molecular method naman tayo, isa sa pinaka-recommended is yung RT-PCR. And aside from that, we have the serological testing using ELISA, kung saan meron tayong two ways kung paano i-detect yun. Una, yung rubella-specific IgM antibodies o kaya naman ang i-detect mo naman ay isa naman sa pang-confirm ng rubella virus ay yung fourfold rise ng rubella-specific IgG antibody titer. Tapos next, we have here the vaccines. Kasama po siya sa MMR na measles, mumps, and rubella nga. Yan. Next. So here in this picture po, papakita lang po yung pinagkaiba ng rubella, tsaka nung Roshella infantum which are considered as child disease. So yun, kung mapapansin natin yung rubella po, yun po yung first disease natin, ordinary measles. Then yung rubella naman, yung third disease natin, which is the German measles.
Hi, how are you? It's me again, Miss De Lima. Before we proceed to discuss mumps virus infection, which is classified under other viral infections, I would like to ask if you're still doing okay. You're not. Same. But who are you kidding? Of course you're doing alright. It's not the end of the world. That's what they say. Anyways, there's two more viruses left, so you better buckle up. It's gonna be another tough ride. So, are you ready? Because I'm not. I should be ready. The mumps virus. This one is similar to rubiola. It is a single-stranded RNA virus that belongs to the Paramyxoviridae family, genus Rubiola virus. It is transmitted from person to person by infected respiratory droplets, saliva, and fomites, and replicates initially in the nasopharynx and regional lymph nodes. If you are not familiar, fomites are inanimate objects or substances that can transmit infectious organisms. Examples of fomites include countertops, handrails, doorknobs, light switches, mobile phones, and clothing. These are things an average person touch on a daily basis, so you better watch out. Excuse me. Following an average incubation period of 14 to 18 days, the virus spreads from the blood to various tissues, including the meninges of the brain, salivary glands, pancreas, testes, and ovaries. Inflammation of the parotid glands or parotitis is the most common clinical manifestation of mumps. As flashed at the previous slide, Parotitis occurs in 30 to 40% of the cases. The illness typically resolves in 7 to 10 days and does not require therapy other than supportive treatment to alleviate the symptoms. One more point to discuss here is that mumps infection in pregnant women results in increased risk for fetal death when it occurs in the first trimester of pregnancy, but fortunately it is not associated with congenital abnormalities. So the number of mumps cases in the US has significantly declined since the introduction of a live attenuated mumps virus vaccine in 1967 and its routine use in childhood immunization schedules in 1977. I am not too sure if this information will come handy given we are in the Philippines, but I also included it here to stress the importance, of course, ng vaccination. So, going back, the vaccine is most commonly combined with the vaccines for rubella and mumps, MMR, or is used in combination with the rubella, mumps, and varicella vaccines, MMRV. You must be familiar with the viruses that were mentioned because all those were already discussed earlier on our group discussion. So, if you were wondering how mumps infection is diagnosed, this slide is for you. You see, the diagnosis of mumps is usually made on the basis of clinical symptoms, especially parotitis, and does not require laboratory confirmation. However, testing is very useful in cases in which parotitis is absent or when differentiation from other causes of parotitis is required. Culture of the mumps virus from clinical specimens is considered to be the gold standard for laboratory confirmation of acute infection. Within the first few days of illness, the mumps virus can be isolated from saliva, urine, CSF, or swabs. Among these, buccal swabs or saliva is usually preferred. Moving on, although culture methods are the gold standard, they require experienced personnel and specialized reagents. As a result, they are being increasingly replaced with molecular detection of viral nucleic acid. Under molecular detection, RT-PCR is the recommended as the primary diagnostic test for mumps because it is more sensitive than serology. As with culture, buccal swabs collected early in the illness provide the best results. Genotyping may be performed to track transmission of the virus during mumps outbreaks. Lastly, still under the laboratory diagnosis of mumps virus, let's explore serological testing, where ELISA takes the spotlight as the commonly used method for detecting mumps antibodies. Known for its sensitivity, specificity, cost effectiveness, and ease of performance, ELISA proves invaluable. To compensate with the incidence of false positive results because of rheumatoid factor, solid phase IgM capture assays are commonly utilized. However, it is essential to be mindful of limitations, such as potential false negative IgM results and lower IgM in individuals vaccinated against mumps. Furthermore, the presence of IgG antibodies, while detectable within 7 to 10 days and persisting for years, doesn't necessarily correlate with neutralizing antibodies conferring immunity. Now, down to the last set of viruses, HTLV1 and HTLV2. Human T-cell lymphotropic virus type 1 and human T-cell lymphotropic virus type 2 are closely related retroviruses. Both viruses have three structural genes, GAG, which codes for viral core proteins, POL, which codes for viral enzyme, and ENV, which encodes proteins in the viral envelope, along with a region code PX, which encodes several regulatory proteins, including TAX. These viruses have RNA as their nucleic acid and the enzyme reverse transcriptase, whose function is to transcribe the viral RNA into DNA. The DNA then becomes integrated into the host cell's genome as a provirus. The provirus can remain in a latent state within infected cells for a prolonged period of time. So, in choosing people you want to hang out with, I'm guessing you have preference. If I am right, then I suppose you and the HTLVs are the same. You see, HTLVs preferentially infect CD4 plus T lymphocytes or helper T cells. But unlike a body like you, they can settle in infecting CD8 plus T cells or cytotoxic T cells, dendritic cells, and macrophages instead. Is our immune response not gonna do anything about this infection, you ask? Are they just gonna pretend HDLVs are not a threat? While CD8 plus cytotoxic lymphocytes effectively control proliferation of virus-infected cells in most individuals. However, inflammatory cytokines released during this immune response may contribute to the pathogenesis of HTLV-associated diseases. In addition, researchers have reported that HTLV-1 infection of CD4 plus T cells can increase production of pro-inflammatory cytokines, impair productions of Th1 cytokines necessary for cell-mediated immunity, and induce differentiation of T regulatory cells. The differentiated T regulatory cells can facilitate viral persistence by suppressing the host's immune response. Now, let me ask you this. Do you believe that prevention is better than cure? If you do, then you should definitely remember this one if you don't want HTLS to consider your insides as their habitat. Transmission routes of HTLVs. What are they? Well, HTLV1 and HTLV2 can be transmitted by three major routes: bloodborne, mainly through transfusions containing cellular components or through intravenous drug abuse; sexual contact, most commonly from men to women; and mother to child, mainly through breastfeeding, sadly. But what do we do if prevention is too late? How do we know if there is already a community of human T-cell lymphotropic viruses within us? The answer is through clinical manifestations. Quite complicated, but I'll tell you now. Although HTLV1 and HTLV2 are both HTLVs, they manifest differently. Let's discuss clinical manifestations under HTLV1 first. HTLV1 is the cause of two diseases: adult T-cell leukemia, such lymphoma or ATL, and HTLV associated myelopathy/tropical spastic paraparesis or HAM/TSP. ATL can be classified into four different subtypes based on clinical manifestations: acute lymphomatous, chronic, and smoldering. Over half of patients have the acute type, an aggressive variant with a median survival of 6 months. All four types of ATL are characterized by a monoclonal proliferation of mature T cells that express the surface markers CD3, CD4, and CD25. The malignant cells have lobulated flower-shaped nuclei that contain proviral HTLV1 nucleic acid. So, in appearance, I placed an image there for easier visualization, diba? It looks cute, but it's photogenet. It's cute, pero sakit siya. Ayun, so let's proceed. So, unlike HTLV1 infections that result with leukemia and myelopathy, the association of HTLV2 infection with disease is unclear. In fact, most individuals infected with the virus are asymptomatic. However, don't underestimate this one since there is still evidence that HTLV2 may rarely be associated with a neurological disease that is similar to HAM/TSP, as well as certain hematologic and dermatological diseases and increased incidence of infections. Now that you know how HTLV infections manifest, the next thing that you should learn about is how it is diagnosed. You see, culture of viruses requires sophisticated techniques that cannot be performed in routine clinical laboratories. Thus, serological testing plays an important role in screening for HTLV infections. Antibodies develop 30 to 90 days post-exposure and persist for life. As such is the case, these antibodies are used to detect HTLV infections in individuals and to screen blood donors. The tests most commonly used for screening are ELISA or CLIA methods that incorporate recombinant antigens or synthetic peptides from both HTLV1 and HTLV2. Now, when it comes to confirmation, commercially available Western blot assays are the ones that are most commonly used. Aside from this method, line immunoassays or LIA and IFA tests have also been developed. Specimens are considered positive if a particular band pattern representing antibodies to the GAG and ENV proteins of HTLV1 or HTLV2 is obtained. Remember though that although these methods, specifically Western blot and LIA, are confirmatory, indeterminate results can still occur requiring pre-testing and PCR for clarification. So, that's all. Bet you didn't see that abrupt ending coming, huh? Well, again, I'm Miss Delima, and these are the last names of my group mates. Hopefully, you've learned something in this discussion. It's my pleasure to be one of the people that helped you in your journey of understanding serology and molecular detection of viral infections. Thank you for listening, and please have an amazing holiday.